I've known Wally for over 20 years now and had a very fruitful collaboration. And I think it demonstrates the strength of the university that we have such people that we can easily find and work together with on interesting projects. So thanks, Wally.
Thanks, Azam. And thanks to Dr. Brooks for the invitation to speak here today. My goals here are to show you the state of where MR image-guided surgery is today. And then the real advances that come are when we have interaction between neurosurgeons and the imaging scientists and engineers, both at academic sites and at the vendors. So you guys have skills that we just don't have. And that interaction is what makes it more relevant and addresses the real gaps. So these are my conflicts of interest. Clairvoyant is I'm no longer with them. Touring Medical develops fast ways for technologists to see if people are moving during high-end diffusion scans, which could be used. And then I also have started a company here called ImageGuide. So why is MR image-guided therapy developed so slowly? MR quickly, came on in the 80s. And by the 90s, every major hospital had an MRI and was doing quite well. I would contend it's kind of the story of the old movie, The Graduate. And there's a classic scene here in The Graduate where Dustin Hoffman's dad's buddy comes up to him and tells him he wants to think about one thing. He wants him to think about plastics. Okay, so this was the 60s. Plastics was the future. So by the early 90s, MRI was making so much money that, as a company, you have to make 10% more money than the year before, okay, to be viable. So the only thing that really excited them in the interventional world was something with high prevalence. Okay, so they chose atrial fibrillation. And atrial fibrillation was in some ways the hardest problem to attack for MRI. You had a breathing person, a heart beating, you had this big cavern so your catheter wasn't constrained to a vessel. And so you were trying then and then you had to map both imaging and electrical properties. So that would have made, that had prevalence to make significant income. But in some ways, I think the most rational place to start is the brain. So minimally invasive surgery in the end, always wins. Smaller incisions, less tissue damage, better outcomes. And so the same things apply in the brain. Smaller access, less CSF drainage and shift during the procedure, better outcomes, faster recovery. So if you think about why brain surgery is ideal for the first purposes of MRI, is because the access to the brain, where there's a lot of redundant function, is at the top. And that's the most natural place where there's access in that long tube, is through the top of the head. There's motion, but just a little. Okay, so when you gain access and there's some CSF drainage, the brain slumps. So you can't count on a stereotactic image in some applications, okay, when precision is really needed. So the MRI provides value there. And the key value, I would say it provides, is once you have your device in place, you can monitor a therapy. Okay, so this is the dominant way that we do things today. The brain is fixated with this clamp here with some head fixation screws, about 4 of them. There's 2 temporal coils placed on the side of the brain, and then access is done through the superior side. The dominant provider is ClearPoint. So what I'm going to try to get across to you today divides with the idea of driving the scanner, guiding devices, monitoring therapy, and then the ability to both predict where therapies are going to go and then to validate them. So driving it just refers to, just think how different, if you worked in a stereotactic OR, the surgeon is king. The surgeon directs the team, different parts of the team come in and out, but surgeon understands how to operate the stealth, brain lab, whatever you're choosing to use, okay? Where in the MR world, you have this complicated interaction with the technologists, physicists, and so that all slows things down. It's foreign to the neurosurgeon. So we need to make advances in driving, but that will come through as we go through the talk. And then we could also have conversations later about your ideas on how better to drive the scanner. Next, I'm going to talk about guiding devices. Okay, so I just talked about the stereotactic OR. You know those images are old, but when you're there, they look like you're looking at the real-time brain. I still remember watching a surgery with Azam where he told a fellow to quit looking at the patient, look at the screen. Okay, because that's how to properly guide a device, align a catheter, a probe, electrode into the brain. 30 frames per second. Okay, MRI works in a different realm. It doesn't work in a geometric realm like CT or ultrasound. It works in a Fourier domain. So it's solid state, but it essentially can take one measurement at a time. If you think about a CT scanner, 64 slice CT scanner with 1,000 detectors per row, that's 64,000 measurements per time. MRI is taking the order of one, maybe with some sophisticated things with coils, we take 8 measurements per time, at a time. So that's why it's so slow. Okay, so here's the ClearPoint device. It uses an iterative means of alignment. There are other FDA-approved devices, the Navigus, but no manufacturers built a simple way of guiding the Navigus. The Navigus is just a ball joint that you can unlock, you can move it, change its orientation, and then lock it down again. Very simple. But again, what happens in this world is the MRI vendors are going to watch development in the realm of neurosurgery. They're not going to get their hands involved in a company day to day. They're going to see if a market grows enough. If it grows enough, then they'll put more resources into it. Okay, so that's the way these interfaces look the way they do, because they had to develop without any real engineering effort of the MR vendor themselves. So here's the workflow for the ClearPoint. First, you need to determine where you're going to center the tower. And you do that by putting this 5 centimeter by 5 centimeter grid. It's filled with vitamin E. And when you can image a 3D image of the brain, you can select your target, and then you can select your entry point. And that entry point then will get, the software will then tell you, it's like a little old game of Battleship, C13. And then you take a little pen and you go to C13 and you poke through and you leave a little mark on the skull. Then you take that grid off and you create your access. Usually that's a craniotomy. Some people would be comfortable fixing the tower later and drilling with a hand drill through the tower. But the tower is not that rigid, so many people are still going to want to create a bigger access through a craniotomy so that they have more leeway in adjusting the device later. Okay, once you install the tower, there's 3 skull screws and 3 standoff screws. Then you go through a series of, the tower itself has an annulus of water around the guide. And so within images get sent from the scanner to the ClearPoint laptop. And that laptop has a model of the device. And that model, then the images are fit to that 3D model. So it knows the orientation of the guide, and it knows where you want to go. And then it tells you how to turn some knobs. So the knobs are 2 degrees of rotation freedom in terms of, think of the polar coordinates like phi and theta. And then then once you get that tuned, you can translate the device. So it's not like the stereotactic OR that's feeling real time. Instead, you image. It suggests to you how to turn the knobs. You turn the knobs. And then once you turn the knobs, you take another set of images. It's like aligning a Christmas tree. You're looking at it from two directions, and that's telling you if you're within alignment. Now, because of the 3D model, it can tell you, estimate your radial error with precision less than the actual voxel sizes, okay? Because it's correlating the whole model to of its device to what it sees. But in reality, because of the hysteresis of the knobs, you're going to get to a point where you feel this is good enough, and then you're going to move through, and you're going to, often you might put a device in, do another 3D image, and see, validate, does that image where that you put a test vial in, say, is that aligned up with my target before you finally insert? Okay, so this is what it looks like on a skull model. And again, just like you guys do a lot of training on phantoms and cadavers, that's where these companies do most of their development and get data for FDA submissions. You can see on the right here, you can see what it looks like with the water in the annulus on a cut frame looks like these lines here. And then you can project that dark line where you're going to go. So in terms of common application, a sleep placement of deep brain stimulators, the value here to MRI is the ability to see the red nucleus on the right. And with that precision, Medtronic, they keep a database of their procedures down to the tenths of a millimeter, how accurate you are in placing the device where you want to be. So within the red nucleus, I don't understand the further skills of delineation of like exactly where you want to place the lead within there. But even someone like me, that's pretty apparent, like where you want to go. I think the real skill in neurosurgery, if you think of a neuroradiologist, has a model of the brain in the axial or sagittal world. When I watch you guys work, what's so impressive is you have a model of the brain along your access route. You have a model along oblique trajectories. You know what you want to miss. You know where there's danger. And that to me is the real skill. And to some extent, your ability to plan that ahead of time has real value in moving these things along. You can see here on this cadaver study, the difference in the size of the artifact, whether you're using a titanium device, say for a biopsy, or a ceramic device, like we might use for an infusion of a chemotherapeutic or a gene therapy. Okay, so in terms of the ability to work in the MR suite, the only thing that's really done is some enhanced ventilation. There's a lot that's done with the ClearPoint and creating a draping system. Okay, the draping system is somewhat complicated, but in this study here, 2.6 infection rate, mostly on the site of entry, 4 in 154 cases, certainly on par with what these procedures are in the stereotactic OR for awake neurosurgery. Not saying that MR is better, but with care, you can get results certainly as good. Okay, next go on talk about monitoring. Okay, so if you think about it, ideas like using ultrasound to heat tissue have been around for a long, long time. Okay, but what made it allow advances, the ability to use ultrasound to ablate tissue, especially in the brain, is the ability to quantitatively monitor what's happening in the brain. Now, so there's a bunch of companies here with different applications. Insight system in terms of being able to do treatments of essential tremor completely non-invasively. That's a $7 million scanner. You might be someday at a site with one of those. The issue is, I think it works really effectively. The problem is, economically, they had hoped that there would be some other therapies that would work in other parts of the body, like uterine fibroids, that probably haven't panned out as much. So it's still primarily, I think, a brain device. ViewRay, those are technologies we have here for, guided cancer treatment. But you can imagine in the case of the skull, what really did change things in ultrasound was the ability to exquisitely measure the thickness of the skull and then model how to get hundreds of ultrasound transducers to work in a cohort to create an ablation. Now, on the simpler realm is the ability to put in a catheter, a laser catheter, and then create an ablation. So we already talked about the DBS on the left, some other applications, you hear from time to time, things like obsessive compulsive disease but that's still speculative. In the area of epilepsy, if you know where you want to go, MRI has this cool property that the temperature will create a phase change in the signal. It's directly proportional to the temperature increase. It's based on the same idea as which you learned about MRI, that fat signal has a different shielding of the hydrogen in it than regular water, and that creates a shift. I couldn't find an image. I was looking for one in the optic nerves, but everyone uses fat suppressed brain imaging now. So I couldn't find one of fat stepping on the optic nerve. But you've seen this perhaps in the body. The pararenal fat here is shifted over, so you see a void on one side and pile up on the other. Why that is, you have current moving around the nucleus, that creates a magnetic field, creates a counter-magnetic field. So in the case of fat, with the carbon bonds in fat, there's more of that shielding, so it's a slightly lower frequency, and that frequency in MRI turns into position. Now, when you heat things, you have to understand that there's more thermal energy, and so the water molecules on average are going to be further apart. And so as they move further apart, the hydrogen in one water molecule doesn't see the surrounding oxygen in other molecules as much. So again, there's more shielding of the magnetic field creates a slightly lower frequency. And if you image it properly, if you wait for a while for that phase change to happen, you can get a temperature-dependent phase shift. So what you do is you first take a reference image. That gives you your reference phase. And then you continue to take images while you're heating the brain. And that phase change then is mapped for you on the screen in a color overlay, showing you the temperature increase. So you can, before you turn on the laser, you can set up your safe zones so that the system will automatically turn off when certain markers get to certain temperatures. You can do this on the order of 8 seconds per image. If you want to track more slices of wider territory, then you're going to have slower temporal updates. Two major companies, Neuroblate has its own frame for placing devices in the brain. And that's, I think, some of a neurosurgeon's personal preference. Some feel comfortable putting the device into the brain in an adjoining OR. Some want to do it in the MR suite. Visualase, the Medtronic product, they use ClearPoint for placing their device in the brain. So you can see the clear color overlay here telling you what you're heating in real time. And this study just came out last year showing efficacy of, of these procedures. And I have some curves showing like how long people stayed at various epileptic-free states on this Engel scale here. So about half the patients 2 years out, so epilepsy-free. This shows you some of the images, what it looks like in a recurrent brain tumor. So at the stage where you're not going to go in again with an invasive surgery, showing you first what the preoperative images looks like in the upper left. Oh, geez, wait. There we go. And then showing you what the catheter looks like here, and then immediately post-surgery, and then 4 months later. What makes it difficult? Okay, well, I already went over your choice of how you're going to put the device into the brain. And I noticed being around you, when you're putting like an electrode in for a measurement, those go in quickly. Obviously, when you're making a decision that's irreversible, those procedures take longer. There's a lot more hemming and hawing. These procedures often have reps from the companies. There's often a lot of interplay back and forth before the actual therapy is done. So what you read in a journal versus what you're going to see day to day in your practice, that also depends on how many of these procedures you're doing and how often you're doing them. We're lucky in that we have physicists on staff to staff these services to keep that familiarity and training of the group strong. The catheter itself is small, 1.6 millimeters. Issues are when you're trying to ablate near a heat sink, like a large vessel or the ventricles, then that could steal some of your heat. Then there's a question of how you're going to be able to ablate in those zones. This is a bigger problem, like in the liver, if you're near large vessels in the liver in ablation. It also, the technique doesn't work well near fat. So that's not so much an issue in the brain. Related technologies where you're trying to use ablation in for bone mets, that would make this technology difficult. Okay, next I want to talk about some things we're doing in intracerebral hemorrhage. So about 100,000 cases in the US per year, a greater prevalence in Japan. Right now, still palliative treatment is largely what's done. Big cost outlays in the first month. It seems to make sense that minimally invasive evacuation of the clot would produce better long-term outcomes. And UW has been a big part of these trials, the MISTY trials, Azam and other surgeons taking part in these, placing a clot-busting drug into the clot at very low doses, and then using CT guidance to see how the clot is being diminished. It's a perfect engineering problem. If you put in too much, you might create a rebleed. You don't put in enough, you're not going to have a sizable enough effect of removing enough of that clot to remove that toxic blood sludge that eventually is going to create greater damage. Goal is to remove about 90% of the clot, and the latest trial is in redesign. We're actually looking at long-term outcomes in different ways. So this is what the trial looked like with CT, stabilizing, making sure the patient's clot wasn't growing the first day, and then 1 millimeter of TPA every 8 hours, and then every 24 hours, taking them in for a CT to see how the clot's changing. To see your options as a neurosurgeon were to move the catheter back. So you don't normally start at the deepest part of the brain. Then as you move back, you could then decide to treat as different spatial regions of the clot. So every 8 hours, you had a decision to make of adding another milliliter of RTPA, and then you'd close that off, let that mix, and then it would gravity drain over the next 8 hours. So this was a trial that was doing well at the UW, but when it went to phase 3 and more neurosurgeons were involved who had perhaps less training, less at stake in the trial, they were probably not taking the therapy as far as others. And so in the end, the trial failed. The trial's outcomes were really about decreasing long-term disability, creating more independence for this type of patient. However, it was determined when there was 15 milliliters or less of clot remaining, those people did have a statistically improved difference in their life stage in terms of independence. So various neurosurgical journals put out calls for tools for this, and my team started working on this. One of the people involved was Matt Henningsen. He's a former UW football player here. He's currently a defensive tackle for the Denver Broncos. So this could be the first and only talk in your career where you see co-author somebody currently in the NFL. So what we did was we created a convolutional neural network, a CNN, for training on cases of work that were present in your practices here at UW. And the goals were to identify the clot and the edema. Edema is a nice surrogate for both likelihood of damage and later for what long-term outcomes are going to be. But this here shows you the advantage of MRI versus CT and MRI's ability through different multiparametric means to create different types of contrast. You can see in the T2 star image that really enhances the iron as it breaks out of the cells. And so that's a region of the clot that's going to take longer to dissolve. But then fluid areas, you see those clearly. And sometimes immediately just putting a syringe or sometimes ventriculostomy catheter into the clot and pulling out that that fluid can have immediate benefits. So here's a simulation that we did, just making a clot and putting a device in and pulling out the bright fluid. So the neural network that we first trained on the cases we had here, and then you measure that your success with something called a DICE coefficient. You have we used expertise from the Department of Neurosurgery to call out the areas of clot and edema on a set of training cases, and then we would take those out of our set and later, and then automatically detect the edema and clot and see how we did. So we had DICE coefficients of about 75%, which kind of sounds low, but if you think about it in a sphere, there's so much volume right on the edge of where the clot is turning into edema. Those are the areas where you're conservative to begin with. But the idea here is that as you look at new therapies, these patients are relatively stable. The MR here at a place like UW is available 24 hours a day. You easily could send them to MRI instead of CT for those assessments, either in a weak therapy like MISTI, or there's companies constantly working on different ideas on evacuation through some type of perturbation or suction. So these were done largely off of 2D images. Our DICE coefficients would go up again if we used 3D imaging. That's what we could actually use your help with in terms of the MRI service, is saying you have a vulnerable patient. How long are you willing to image? What's the most important things you want to see on that patient? And then how could we use that time to make better images of the clot and edema? Okay, so the last thing I want to talk about is convection enhanced delivery, the ability to direct therapeutics past the blood-brain barrier. was largely done first in pediatric brain cancer and adult brain cancer. And the idea is, if I can start this movie. Wait. Is there a chance you can move the mouse to, there's a movie within the video right there. So under pressure, we can deliver therapeutics on the order of, 1 to 20 microliters per minute. And it moves through the interstitial space of the brain. So it's kind of like a sledgehammer to get past the blood-brain barrier. These therapies have been used over and over again, largely at Duke, with John Sampson, with the Brain Cancer Center there. There have been some exciting things now with ultrasound, being able to, with bubbles, being able to disturb the tight junctions of capillaries. So you can deliver some chemotherapeutics systemically using those kind of ideas. But this is when we just, again, putting a catheter, the catheters are on the order of 1 millimeter in size, the tips on the order of 1/10 of a millimeter. And then it's a game kind of I joke called advanced whack-a-mole, because what's going to happen is we're going to see different distribution rates. You can't just put a catheter and say, I think this is where it's going to go. And we're going to talk about why that is. Okay. So there are pre-surgical modeling platforms that are FDA approved on BrainLab called iPlan Flow. Besides the ability to predict ahead of time, where should I put my catheters, what my distribution is going to be, then MRI would also has value in terms of real-time monitoring to see how you're doing as the infusion's starting. So in terms of the brain, the interstitial spaces are in the order of 50 to 100 nanometers. If we look at trying to put in something as large as a stem cell, that's huge. That's not going to move anywhere. But an MR contrast agent, that has free ability to move around, as well as viral vectors. Those are only in the order of 20 nanometers. Those can move around quite simply. So while no large molecules will make it past the blood-brain barrier, and very few small molecules will, all the therapeutics that have been looked at for brain cancer, they can move around freely, and they've been shown to show up wherever the buffer is. So the buffer is easy to see just through differences in T2, or you can simply add a little gadolinium into your buffer, and that one then T1 weighted imaging will show you where you are. So the trick is that diffusion is a very poor way to move drugs around the brain. What you need is some type of pressure to move things through that space. But once you start that, one of the advantages is that the concentration is real easy. It's a flat top. So again, wherever you see the buffer is where your therapeutic is moving. And there's a movie here on the left side. Caleb, sorry. There's a movie on the left side, or right there. So the difficulty in using these technologies, as you think about white matter, because it's organized with myelin, it can expand under pressure more easily than gray matter. So it's effectively a lower resistance pathway. So CED infusions, once they get to white matter, tend to race along white matter tracks. The other aspect is the perivascular system. The perivascular system acts as an unwanted sink because that's another low resistance pathway. So big differences in the pore fraction, the space between the cells, will create big differences in the rate that these drugs or biologics move through the brain. Okay, so in terms of prediction, interstitial spaces, those are good. Sulci, those are bad. Perivascular spaces are bad. In the area of cancer, tumors, capillary changes that are breaking down the blood-brain barrier are also bad in terms of stealing our therapies. So what this iPlan flow algorithm does is uses MRI as a clever surrogate by using diffusion tensor imaging to map out the white matter. So we can segment the brain to know areas that are going to have different hydraulic connectivities. So it's really a promise similar to oil research. Like oil research, if I put this sand in here, where will the oil come out? In the brain, it's if I put my catheters in here, where will the drugs flow? So the surgeon ahead of time would place catheters where they feel they were comfortable placing the catheters. They would set parameters. It's all a forward model. How long am I willing to infuse and at what flow rates? And then the forward model shows you where you're likely to treat. Okay, so in terms of the mathematics, it's figuring out pressure. Pressure translates to velocity, and then velocity translates to where the drug or biologic is going to go. So this describes what that process would look like on iPlan flow. Again, largely used in adult trials to date. You can see in this paper, the predicted distribution. Don't look so much at the colors, look at the spatial distribution that matches up very well with the measured. Okay. The concentration is difficult to predict in terms because often you're going to do these infusions over days to actually over days. And so you're going to have ebbing and flowing of that concentration, but you're still having a treatment effect. This is what it looks like in terms of the interface that the surgeon would work with. On the left, various cut planes where you place your catheters and then again seeing your end distribution. This is a localized idea for a trial that was done for a gene therapy for Parkinson's and the putamen. Here, the idea was to just treat the putamen. So 3 catheters were used because of the oblong shape of the putamen. So in this idea, in terms of using MRI to its natural, logical extension would be to pre-surgically plan the infusion and then to periodically with MRI, see where your infusion's going. Because that gives you the chance to move your catheters or change flow rates to get the end distribution that you want. This is some work that we did with Therataxis, the people who developed the algorithm for iPlan flow, where we would look at the infusion early on and see how it was growing. That created a 3D velocity field here shown in color about the infusion ball. And we could use that to basically use new catheters, new high-end catheters, instead of just the catheters that are FDA approved today that leave infusate coming out from one tip, but from porous membranes that create wider distributions. So this shows the value of this. If the gray is the actual infusion, what was done, and then the color overlays on the top show what the prediction was, and the middle row show our prediction when we took into account how the infusion was going very early on in the first 20 minutes. So there's areas that the arrows that show predicted over treatment, more treatment than actually occurred that was properly predicted by doing some monitoring early on in the procedure. Okay, so here's the value of the pre-surgical planning. MRI again being used for surrogates of the hydraulic conductivity parameters that for the field is called poroelasticity. And then the value of monitoring during the infusions to see what's actually going on and giving the surgeon some chance to do some changes in the procedure if needed. And again, so the value of using this with MRI is less domain expertise needed by the neurosurgeon and the team to know what actually is going on because you have a real-time look at that. We've done some interesting things with Ned Kalin in the area of changing anxiety profiles in non-human primates by changing a protein expression just in a small region of the amygdala. We've also guided procedures with Marina Emberg for placing stem cells in the substantia nigra for a Parkinson's model that was shown in Nature Medicine. Last thing I'm quickly talk about is an opportunity I think we have here at UW-Madison. If you think of UW-Madison, 20, 30 years ago, it didn't make sense that it should have been the liver and kidney transplant center for the Midwest. Okay, there were bigger population centers elsewhere, but people saw that opportunity, and now we are that center. There's exciting things going to be coming out in rare neurodegenerative diseases that by molecular biology, we know how to cure them. But the problem is drug delivery, getting it to treat a large enough region of the brain. So this child here on the left, he was, he's the same age as my son, who was there. My son's now 18. And my mother and his grandmother knew each other, and they would go through their milestones when they're 3 months, 6 months, 12 months. But about 2.5, he started having some real problems, vision problems, stumbling. Turns out he had Batten disease. Took about 1.5 years to diagnose it. Then his poor sister, Lainey, had it as well. So Noah, his father was a trader on the Board of Trade in Chicago, but he became, like a lot of these parents, became an expert in the disease. He created a lot of the interesting mechanisms or spurred those with the FDA. So right now, the rare disease space pharmaceutically is well off. They're billion-dollar companies. People, in a lot of ways, these gain of function diseases where there's just one gene off, they know how to create the viral vectors to cure them. So Noah's dad convinced this company BioMarin to come up with an enzymatic treatment. And this was done at UW. This was featured on the front page of the paper last summer, where the protein that's accumulating in the brain is removed through this enzymatic treatment that's put into the ventricles every 2 weeks. And this dramatically slows the disease, but the end stage is still death early on in somewhere in adolescence. These companies would be interested in moving to cures. Again, the therapy itself is well understood. The problem is we need to take the technologies that people have done in brain cancer. Granted, those haven't worked in chemotherapy, but the drugs went where they were supposed to go, okay, to treat wider segments of the brain. So I joked before, it's kind of like advanced whack-a-mole, because the infusate without care will exit through low resistance pathways. What we need is to create a second generation of the iPlan flow so that neurosurgeons like yourself working with pharmaceutical companies could say, I'd be happy putting my catheters here and cerebellum for an ataxia. And then once the companies know what their likely distributions are, then they would be spurred to come up with a program. So I'm a member of the FDA Critical Path Committee for Lysosomal Storage Diseases, of which Batten's is one of them, Niemann-Pick, another. So where we need to go in terms of this is that all these therapies that have been tried to date, have been on adults. It's going to make sense that we're going to want to treat these kids before the damage actually accumulates. So we need to make next generation tools that work on the rapidly developing brain where myelination is changing. And so we're looking at some of the exciting new models that are being done here at UW. People like Drew Dean and Andy Alexander are advancing, where typically DTI imaging has been done primarily for research, brain mapping, and for neurosurgeons to understand if I do a treatment in the brain, where are the white matter tracts that I want to save? Where are the ones that are the most problematic? But there's higher order models that are going to allow us to look more and understand that interstitial space. So this is work that we are submitting with Wendell Lake to the ASSFN meeting, showing how these models can properly predict where infusions are likely to go. You know, in brain cancer, that edema is less likely to move towards the corpus callosum because of neural density. And these models are properly showing us where, you know, where the differences are in extracellular space. So I'll just close with these opportunities. We need neurosurgeons to help us understand your workflow experience so that we can speed these procedures so that they become more relevant to your day-to-day operation. We need investment in the area of CED to do inverse modeling. So you could say, I want to treat this area of the brain. What are my opportunities for placing catheters, rather than to place catheters and then see what the resulting therapy would be. We need other parts of your expertise to speed workflows, especially for the pediatric cases, because we're going to need to place lots of catheters in to create coverage, and develop tiered strategies, because talking with some of the pharmaceutical companies, we likely don't have to treat the whole brain all at once. We could start treating portions of it and then use other type of ideas, both inside out and outside in. So again, look at where we are with liver transplants, kidney transplants here at UW. Meanwhile, at the FDA, there's a lot of excitement and interest in using ideas that came out of COVID, Operation Warp Speed, to move them into these rare diseases. We have the expertise on campus to make the therapies. There was a trial here done with a kid with Batten's last year. But again, where the drug is administered, it's working. The trick is to develop technologies with you to treat wider tracts of the brain. So with that, I'd like to thank all the people who've been involved with this work. Thank you for your attention. Thanks for the opportunity to speak with you today.
I think what you're telling us really is that functional neurosurgery is going to become regenerative neurosurgery. And this idea of interrupting pathways of electricity is going to move toward placing enzymes, placing genes, placing cells in individual micro catheter placed areas that we've got, which is what we're really trying to improve in that. Questions?
On the last slide, you mentioned that there's work now being done to first prediction flow, right? Is that work using machine learning help with that process?
That's interesting, because people say, why don't you just use machine learning? You know, and the problem is data, right? Like there just haven't been enough trials, certainly with children. There have been trials with brain cancer and stuff. And of course, in the world of brain cancer, every tumor to me looks so different, like in terms of which ways it evades and stuff. So I think in the near term, we're going to use old-fashioned physics to say, the poroelastic field, you can imagine the billions of dollars that have been poured into that for oil research. So we can use those parallels for the brain. And so whenever you can leverage technology development in other areas for areas where the prevalence is low, I think that's a wise strategy.
We have to get our words. Okay. So, thank you very much.
Okay.